Okay, so good morning. This is Dr. Endymion Tan. So I'll be doing the lecture in the physiology of vision. So I know that it might be a little bit more difficult if we do this online because of course there will be some concepts, and you know that I love to write on the board in multicolored chalks to help you decipher and understand the topic. But of course, I'll promise you I'll try to make this very simple. And of course, you should be reading your books, and some of the concepts in the books will be harder to understand and comprehend, but we will try to make it more simple and easier to understand. And just in case if you have some concepts or questions that you cannot understand or a little bit blurry or fuzzy to you, next week when I do my lecture in motor physiology, you can always ask me, then we can try to reiterate some of the queries that you have. Okay, so of course, for the objectives in the physiology of vision, this would be one of the special senses in the physiology B topics. So we'll be talking about briefly on the functional anatomy. So what will be the parts of the eye? And then of course, we have to talk about the optics of vision. We'll be talking about some of the errors of refraction, some concepts, okay, about the lenses, some concepts about accommodation. And then we'll have a short break. Then we'll go to the part 2, which is the retina. And of course, in the retina, it is already the neural part of the physiology of vision. And the last part, we'll be talking about some diseases, patterns of blindness, and of course, the cortex. And we will be focusing on the central part of the brain, yung pinaka-higher of the highest centers in the physiology of vision, the brain in itself, the visual cortex. Okay, so let's start. I know it's a longer topic than higher center. We'll finish in roughly 2 hours and 20 minutes, the usual pace that I do, but we'll try to make it more simple and livelier. No, I know it's hard. Ay, hindi na siya nag-move. Okay, so this is a cross-sectional view of the eyeball. Of course, you'll see the anterior part. I think you can see the cursor that I'm pointing to, yes? Yeah, so this is the anterior part of the eye. Of course, you can see the cornea. And here at the central part here, pointed in this cursor, you will see the opening in the eye. That's the black part of the eye that you will be able to see when you look at your seatmates right now. But I know you don't have a seatmate right now. When you go to your laboratory class, you'll be doing some experiments and you'll be looking at the pupil. That is a black part of the eye. That is the opening of the part. That is a pupil. And of course, a colored part of the eye, well, since we are Asian, so we don't have much options for you to see. Yung colored part of the eye, that is what we call the iris. So later on, we'll be talking about this part in particular, the lens, the ciliary muscles, the suspensory ligaments, the pupils, especially when we will be discussing the concepts of accommodation. And of course, we will be discussing about refraction. So we'll be talking about the cornea. And then later on, in the middle part of the lecture, you will be discussing, okay, or you will see some pictures of this vitreous humor and the aqueous humor. Mamaya, you will know what will be the differences between the aqueous and the vitreous humor as to the consistency of the fluid, because those humors, those aqueous and the vitreous, especially the vitreous humor with this gel-like inconsistency, will give you the globular shape of the eyeball, because your eyeballs are not flat. Your eyeballs are not triangle. They are globular. It is because of the gel-like consistency of your vitreous humor that would give it the globular shape, and of course the ocular pressure. Okay? And here, what I've promised, we'll be talking about the retina. When we talk about the retina, we'll be talking about the blood vessels, and of course, we'll be talking about the receptors in vision, which will be found in the retina. And of course, we'll be talking about the optic nerve, then up to the brain. Now, the first concepts, of course, when I do lectures, you have to understand some concepts. When I say refraction of light, in Tagalog, ano yung refraction? Bending. Well, bending is English. Refraction means binabaluktot, okay? You bend the light. Refraction. Because light rays will travel in air. In air, walang impedance masyado. In air, at a speed of 300,000 kilometers per second. That is pretty fast. That is the speed of light in air. However, when these particular light rays will hit a medium, When I say a medium, it can be a transparent medium, it can be a translucent medium, it can be an opaque medium. So examples of media, what do you have? You have glass, you have prism, you have a block of wood, etc. So when this light rays will hit a medium, whatever this medium will be, there will be bending of light rays. So in physiological parlance, or in the terminology, bending of light rays is what we call refraction. So refraction is basically defined as the bending of light rays at an angulated surface on a particular medium. Take note, if the refractive index, okay, is higher, mas mataas, because normally it is 300,000 divided by 300,000. The numerator is the speed of light in air versus the denominator, the speed of light in air. 300,000 divided by 300,000 is 1. So 1 is a basic refractive index. Please silence your microphone so we don't have distractions. So the refractive index of light is at least 1. However, if this medium, this particular piece of glass or whatever itong medium would have a very high refractive index, meaning to say the light rays has to travel through this medium, but this medium will tend to bend the light rays. So the refractive index would be higher. So the higher ability of a particular medium to bend light rays, the refractive index will be higher. Glass has a very low refractive index. That's why when this piece of glass will bend these light rays, you will not see much of a fire or a reflection or the bending. However, if you're familiar with certain gemstones, for example, diamond has a refractive index of around 2.5. Meaning to say, as compared to air, which is 1, a piece of diamond, highly polished, many facets, will have a refractive index of 2.5, roughly. So the higher the refractive index of a piece of a gemstone, the higher the ability for it to bend light rays. That's why if that piece of gem will bend the light rays, you will see the reflection, you will see the fire. Yun yung nakikita mong kinang or the brilliance or the fire. So the higher is the refractive index, the higher is the bending of light rays, the higher is that ability of that medium to give you the reflection or the bending of light rays. So you will see this analogy when we talk about the cornea, the lens, the aqueous humor, and the vitreous humor. Because later on, you will know which part of the eye, the one that I have showed you in cross-section, will have the highest refractive index. You might think it is the lens, but who knows, it might not be, and we will know what's the reason behind that. Okay? So basically, the optics of vision, we'll be talking about the lenses and the refraction. Basically, we have two types of lenses. We have the spherical and the cylindrical lenses. So first, let's try to talk about the spherical lenses. For a spherical lens, actually, you have examples. You have here on your right side of the screen, you have a concave lens. Here on the left side, you have a convex lens. But whatever type of that lens, of that spherical lens, usually these spherical lenses can have the ability to bend light rays. Take a look at this convex lens. Take a look again at this convex. This is convex shape. Convex, okay? So first, look at this lens, and these parallel lines are the light rays. When I say light from a distant source, distant, malayo, okay? So light rays from a very far source, malayuan, 10 meters apart, you will able to see that object because that object is emitting light rays. So these light rays from a very far source will hit your lens. Example, this is your convex lens, as what I've told you. This convex lens, take note, will tend to bend the light rays because there's refraction. So bending of the light rays would enable this parallel or kung saan man yung source of these light rays, okay, converge to a common point of focus. The convergence or the common point where the light rays will meet, okay, is what we call the focal point. And the distance from one edge of the lens to the focal point is the focal length. Therefore, later on, we have to understand by heart what is the relationship of the power of the lens to the focal point and to the focal length. If the lens is more convex, is it more powerful? If it is more powerful, it can bend light rays more. So if it can bend the light rays more, imagine if this is thicker, this can bend the light rays more than this piece of convex lens. So if this is more powerful, the focal point would be nearer to the lens because mas nabebending light rays. So the focal point would be nearer to the edge of this lens. The focal length would be shorter. So the proximity of the focal point is nearer to the lens. The focal length is shorter. Okay? So mas malapit si focal point, therefore the focal length is shorter. You will see pictures later on. Okay? So again, that's what I've told you. We have two types of lenses. We have your spherical and your cylindrical lenses. Spherical lenses will give you a focal point, which is the point of focus when you converge all those light rays. Okay? Point of convergence. However, a focal line, okay, is seen among cylindrical lenses. Cylindrical lenses, take a look at this figure letter B. This is an example of cylindrical lens. Okay, I know you have been through your chemistry classes in your high school or your pre-med courses. Have you ever wondered if you get a piece of a graduated cylinder or test tube, especially who are the med techs here? Diba, you deal with test tubes. For example, wala akong makita test tube dito sa bahay, of course. So if you get a piece of test tube and you shine it or you put it just across, for example, a beam of light, no, dito sa sun, and then you take a look kung saan siya mag-focus, it will give you a line of focus. It will not give you a certain point. But during your younger days, have you tried this experiment? Diba, you get some paper or yung matuyo na dahon, and then you get your grandfather's magnifying glass. That magnifying glass is an example of spherical lens. What happens when you shine that magnifying glass towards dun sa sunlight? You will burn that piece of paper. Why? Because you will have a focal point of focus, because spherical lenses will give you a focal point, while cylindrical lenses will not give you a focal point, but it will give you a focal line. But in the optics of vision, if you put two cylindrical lenses at right angle to each other, so two cylindrical lenses is equivalent to one spherical lens. Therefore, 1 plus 1, so two cylindrical lenses will give you one spherical lens. Therefore, will you have a focal point? Yes or no? Feel free to answer, but the answer is yes, because two cylindrical lenses is equivalent to one spherical lens. And with spherical lens, what did we say? You will have a point of focus, which is called the focal point. Okay? You will be able to appreciate these principles when you go to the laboratory part of vision, because we have certain setups, especially in the optics na part, no, when you'll see the point of focus of those objects that will be shown to you. Later on, I think this is one of the semesters, no, that I'll be adding in the explanation, because you've heard of the eclipse, the solar eclipses. One particular way for you to see the eclipse is not looking at the sun. You will see the focal point where it will focus if you have your own setup. We'll talk about that later on, or in the laboratory part if we have more time. Okay? Now, remember I told you about the focal length. It is the distance kung gaano kalayo. It is the distance beyond a convex lens. So at one edge of the lens, to the point where it would focus to a convergent point. Okay, that is a focal point. Imagine, look at these three figures, these lenses on your right side of the screen. What can you say about the shapes of these two lenses? Same, right? Pareho. Pareho siya. These two lenses, the same shape, the same size. Therefore, they would have the same power. However, what differences can you see? Because one of the commonalities that you can see is both of them can bend the light rays. Another commonality is they have the same shape. So what would be the differences that you can see? Look at the focal point. You have two different focal points. One is nearer to the lens, one is farther away from the lens. Another difference that you can see is the focal length. The focal length is shorter here as compared to the focal length here. Mas mahaba, mas malayo si focal point. Why? Bakit? You have the same shape, you have the same power of the lens. How come your focal point, one is nearer, one is farther away? Take a look. If you're very keen in observing, light rays from a very distant source, very far source, malayo, they would be in a parallel. See, they will be in a parallel projection like this one. If you have a light source from a very near source like this one, are they parallel? Initially, they are not actually. See? Can you see the differences? So light rays from a distant source, okay, malayuan, once it enters the eye, dito siya mag-bend. However, if you have a very near source, a very point source of light, okay, so of course this point source of light will be more scattered, divergent, and then once these divergent light rays will hit the lens of the eye, or you have a piece of convex lens, mag-bend na siya. However, it was not given enough time or enough distance to bend and focus at this focal point if this is your desired focal point. Because sobrang lapit. Sobrang lapit. That is why some older individuals, di ba kapag majonders na, matanda na, if yung light source or if yung object that they are trying to read is very near, imagine it is mimicking or simulating this figure letter B here. If the light source of the object is very near and matanda na ako, my lens cannot change its shape. Can I see the object clearly? No, because that object, that light source will fall where? At which part of the focal point? Way beyond the retina, very far. That's why the object is not in focus. That's why older people, they need light source or that object to be put farther away. Kaya pinapalayo nila. So this is simulating figure A, light from a distant or farther away na source. Because if it is farther away, it would be given a more chance or more distance for that light rays to reach the eye, to be bent, and to reach this particular desired focal point. So if this is the case, the focal point is so far away, pero gusto kong magbasa ng ganyan lang kalapit. I want to read this book at this distance, very short distance. If I am younger, that is possible. What can you do? You cannot pull your retina. You cannot change the anatomy of your eyeball or your skull. You cannot do that. But how can you do it? We are blessed because inside the eye, we have the lens system, which we'll talk about later. This lens system can change the shape. If you make this thicker and if you change the shape, mas kumakapal siya, it would have more ability to bend the light rays. So take a look at figure letter C and figure letter A. Two different light sources. One is from a very far source. One is from a very near source. However, you have the same focal point. You have the same focal length. What's the reason behind that? It is because you are able to change the shape of the lens. It becomes more convex. The higher is the convexity or the thicker, mas makapal. The higher is the power of that lens. The higher is the ability to bend light rays. Okay, and the ability of a particular piece of lens to bend light rays, the power of the lens, or what we call the refractive power of the lens, is called the diopter. So I guess this is section B. Section B to, if I remember correctly. Section B, yeah, this is B, Wednesday class. I can remember some of you or most of you are wearing eyeglasses. So the power of your eyeglasses that you are wearing is measured by the unit called diopter. Yung sasabi natin na, ay magpapagwapo ako ng salamin. Anong grado ng eyeglasses mo? 200. That 200 is a 2.00 diopter. So your lenses, so starting from now on, okay, if I'll ask you, what is the power of your lens, of your eyeglasses, or of your contact lenses, it will be better if you report it as, oh, doc, it is a -2 diopter, minus 5.50, so 550, minus 5.50 diopter. So mas medically inclined, no? Mas maganda pakinggan. Rather than sabihin natin, doc, 550 po yung grado ko. 550, so it can be 550 diopter. It's not. It is 5.50 diopter. And you will appreciate this one if we do the laboratory in the optics of vision on how you do that. What do I mean by neutralization? When I say neutralization, it is like 1, so +1, -1 is 0. What does that mean? If this is my normal eye, I have no errors of refraction, pero maarte ako. I want to buy a contact lens, the color green. However, yung contact lens sa color green, wala siya sa normal na vision ko. They only have for nearsightedness -1 diopter. So I'll wear that -1 diopter. And then labo-labo ng paningin ko. So how can you neutralize this -1 diopter? What can you give? Of course, you give something that would oppose this -1. So you give a +1. So I can wear a contact lens in a -1 diopter, but blurred ang vision ko. So I can wear a piece of eyeglass na lens with a +1 diopter. So you can add up or you can play with those diopters. So +1, -1, you neutralize. Or you are wearing a -2 diopter and then you superimpose a +2 diopter. So that is what we call neutralization. You can do that actually. So later on, no, dito, hindi ko masyadong tuturuan kayo kung how to compute, how many diopters is this particular piece of lens, because I want you to appreciate this one when you do the laboratory part, because you have to compute for the diopter of a particular unknown lens that we will be giving you in the lab, okay? It will be fun, okay? So now, the eye as a camera. I can see some of you, because some of you invited me in Facebook or Instagram, so I've already seen your Instagram pictures. Some of you are very fond of taking pictures then, very good photographers. And did you know that a camera, okay, is said to function like the human eye or eye of any individuals, no? So it is said to be the eye as a camera. Why? What's the analogy behind that, no? Oh, I think someone's asking a question. You add, okay, we'll try to answer all those questions later. Just feel free to type in if you want, okay? The eye is compared to a camera or vice versa. Why? We have analogies. In a camera, isn't it that you have that lens? Diba? You change the lens if you have, kung social ka, you have those telephoto lens or you have those wide angle lens. So that lens of your camera is compared to what? Of course, that lens, the crystalline lens of your eye. And then your camera has the f-stop, okay? Yung aperture system. Ano yung aperture system? You want itong camera mo to function more in a low light or in a very bright sunlight na environment. So you can change the f-stop. Meaning to say that smaller is the opening of the camera, it is mimicking the smaller size of the pupil. If the opening of the camera is bigger, you are mimicking the bigger size of your pupil. So the aperture system, yung pag-open, pag-close system of that camera is compared to the pupil of your eye. And of course, if you have a digital camera, that image should be registered where? In the memory card or in your screen. Where it is being registered, or in old-fashioned cameras, those 35mm lens na camera, that image should be registered where? In that film, Polaroid film, Kodak film, or whatever film that you're using. And in our human eye, that image seen or perceived would be registered where? In the retina. Take note. Inverted and reversed image. What do I mean by this one? Look at this picture of this baseball player. Inverted image. Since the lens of the eye can bend the light rays, everything on top of the visual field will be bent and will be registered at the bottom part. The lower part of the visual field will be registered where? In the superior part of the visual field. And then you will see the left will be registered on the right will be registered on the left. So there's inversion of image. And there is one particular experiment in the laboratory wherein you can appreciate that inversion of image. And you will do that in the laboratory part, and you will report to us what do you call that thing that you can see when you do this experiment, when you do that activity, and how come it is here and not over there? Why it is on the right side, bakit hindi na sa left? You will appreciate those. But because there's inversion of image, okay, right will be registered on the left, up will be registered on the bottom part, etc. Okay, accordingly, so you'll be able to answer that. Look at this picture. It is said the total refractive power of a normal physiologic human eye would be 59 diopters. It is very powerful. Now, let me turn the question to you. So which part of that eye do you think would have the highest refractive index? Hi, pa-silent please. But if you'd like to answer, you can unmute, no? So which part of the eye do you think would have the highest refractive index? Yung pinakamagaling, pinakamalakas magbend ng light rays. You might think that it is the lens, but I will tell you it is not. Why? Remember the principle about refraction. When the light rays will travel in air, it travels at a speed of 300,000 meters per second. So, ganun siya kabilis. So, the refractive index of light rays in air is 1.00. What is the next medium? The cornea. Now, we'll be talking about the impedance. Gano'n ba kalakas yung cornea para i-block, para i-bend tong light rays? So, there's a gradient. There's a difference. The impedance is 0.38. Where did I derive the 0.38? 1.38 is said to be the refractive index of the cornea. 1.38 minus 1.00, it is 0.38. So you have an impedance of 0.38, a gradient or a difference of 0.38. Next, the light rays will enter the cornea. The cornea and the aqueous humor interface will be how much? 1.38 minus 1.33, 0.05. 0.05 is arithmetically lesser or lower than 0.38. Therefore, automatic, mas talo, hindi aqueous humor ang pinaka-best. Next, look at the aqueous humor and the lens interface. 1.4 minus 1.33, that is 0.07, slightly higher than the cornea and the aqueous humor interface, but can it beat, can it surpass the interface of air and the cornea, which is 0.38? Hindi. No? 0.07 lang ito. How about the lens and the vitreous humor? You deduct this one, you get an interface of 0.06. So it is still way lower. That's why it is said the total refractive power of the eye, even though it is 59 diopters, the cornea would still have the highest refractive index because of the interface between the air and the cornea, which is 0.38. So malaki yung agwat, malaki yung gradient, malaki yung difference. Things would change if this patient will wear a contact lens because it will become what? The air contact lens interface. Okay? So assuming this is physiologic, normal, so it has to be the air corneal interface that has the highest impedance. So it will have the highest refractive index. Take a look. The total refractive power of the eye is 59 diopter. But tingnan natin. The lens of the eye is just 20 diopter. 20 is not even 50% of 59 diopter. Less than half. So talagang hindi siya yung pinakamalakas. But we are just very lucky because when you're young, well, kasama pa naman ako dyan sa age group kasi wala pa ako presbyopia. Well, ano lang, age is just a number. When we are young, actually, no, your lens of the eye can still change the shape. What did I tell you earlier about the changing of the shape of the lens? If a particular piece of lens can change its shape, assuming that the lens of our eye can increase its convexity, it can become thicker, then it will have more power. That's why the lens of the eye, our human eye, can change from 20 diopter to 34 diopters. We are just so blessed with that. So it can change. And this is the process or the power of what we call the accommodation. Let's try to talk about accommodation. When you say accommodation, you will see certain things that will happen, certain steps that will happen. Hindi lang siya kapag you accommodate, you increase the thickness of the length. It is not that quick. You have to know the principles. First, let's try to talk about the ciliary muscles. Because accommodation, this principle is very important. For sure, it will be in the exam. The ciliary muscles are very important. Okay, can you, oh, I have a picture, ito. Can you see this thing? Yes, this is a bell. So assuming that this is convex in shape, this is the lens of the eye. You can see this. And this one can change the shape. Nakikita nyo? Flatter, thicker. If this is flatter, the power is lesser. Sabihin natin mas flat, mas hindi siya powerful. If this is more rounded, more convex, the power of the lens is more higher, is thicker because of that thing. Normally, luluwag, I'll try to make this looser para hindi masira. Okay. So normally, physiologically, if this is like this shape, the lens, okay? Here at the side, at the periphery, this particular lens, look at my hand, my finger. It moves, diba? Because my fingers are acting as the suspensory ligaments. Suspensory ligaments. They suspend that lens, okay? Suspensory ligaments. And one end of the suspensory ligaments, of course, will be connected to the ciliary muscles. Can you see? Here, okay? The suspensory ligaments, can you see the picture? Lens, suspensory ligaments, ciliary muscles, like this thing that I'm holding, this bell. If normal, no, I do not need a very thick lens. It is like that. But if I need to have a higher power, bibilog siya. So, contraction of your ciliary muscles will make the lens thicker and more powerful. So kapag normally in this picture here, the suspensory ligaments medyo, ano siya, banat, no? Medyo banat siya. So when the suspensory ligaments are pulling, are very tight, are very taut, they are shorter. Do you follow? Normal resting face. Flat yung lens ko, therefore my suspensory ligaments are taut, are very tight. They are pulling on that lens para maging flat. So the length of my suspensory ligaments would be shorter and they are tighter. But when I contract my ciliary muscles, when I shorten or contract my ciliary muscles, the suspensory ligaments mag-bounce in. So the suspensory ligaments become longer. When they are become longer, hindi na siya ganun kahigpit. They are more loose, they are more laxed. Pag they are more lax, hindi na niya hinihila yung lens. This lens becomes rounder kasi mas nawawala ni banat niya. So mas rounder. So when I contract the ciliary muscles, I want accommodation to occur. But for accommodation to occur, the ciliary muscles will contract, the suspensory ligaments will lengthen. When I lengthen the suspensory ligaments, they are loose, they are laxed. Then the power of the lens increases because the convexity increases. The opposite occurs when there's no accommodation. Hindi ko naman kailangan makapal yung lens ko. Resting face. You don't have to have a very high diopter. The suspensory ligaments are very short. They're very tight and very taut because they're pulling the lens. So the lens appears flatter. Do you follow? This is the principle of accommodation. Because when you are young and you can do accommodation, you can change the power of the lens. From the low 20, it can go as high as a 34 diopter. That's why if you're younger, if you're reading your text, you can read it, or when you're watching Netflix, you can watch it like this distance, farther away, no problem. Your eyes can accommodate. But when you are older, theoretically 40s and above, no? Buti na lang wala pa akong presbyopia. Oh my God. Your eyes will slowly lose the power to accommodate. So some of your parents or friends or older relatives, they might not be able to watch a movie or read a text at this particular distance. Kailangan layuin nila konti because they are slowly losing the power of accommodation. And you have to remember the ciliary muscles, the lens, and the suspensory ligaments. Remember, the ciliary muscles is not the same with circular muscles. Tandaan niyo yan, ha? We'll be talking about the circular muscles later because you might be confused with the ciliary and the circular muscles. Okay? Yan yung sinasabi ko, presbyopia. Normally, a young individual can have a change of 14 diopters. From 20, it will become 34. But when you are reaching 45 to 50, maybe 2 years from now, less than 2 na lang yung diopter na pwedeng i-change ng eye ko. When I reach 70, 0 diopter, as in I cannot accommodate anymore. I might have presbyopia already by then. So I will lose the power of accommodation. So you need your bifocal lenses, your glasses to help you read. No? So you will see these errors of refraction na pag-usapan natin in the next few slides in the laboratory because you will mimic those in the optics of vision with that experiment. Now, this one, sayang no, hindi tayo face-to-face because I usually do parang a picture taking when I talk about the pupils and the depth of focus. Before we talk about the depth of focus, what is the meaning of the word depth in Tagalog? Gaano kalalim? The swimming pool, if it is mababaw, what do you call it in English? Very shallow. Pag malalim, it is very deep. So when we talk about the depth of focus, the jargons that we are going to use would be shallow and deep. Okay? So is the depth of focus more shallow or shallower, or is the depth of focus deeper? So, mababaw or malalim? So, let's try to talk about this one. I told you that the pupils can change the shape or the size or the opening. They can become pinpoint or they can become a more rounded shape, malaki, very dilated. Remember, a very pinpoint constricted pupil is miosis. A very dilated, dilat. A very dilated pupil is called mydriasis. To help you remember, mydriasis has a letter D, mydriasis. Dilate has a letter D. So dilation, dilat, pupillary dilation is mydriasis. Pupillary constriction is miosis. Do you follow? Okay? Sige. I'll ask you one question. If you'll take a selfie or a group picture. So you have your classmates seated in front, you have your friends nandun sa gitna, and you have your friends at the back. So if you take a selfie like this one, ikaw yung kumukuha. And then you have friends in the middle, you have friends at the back. I'll ask you one question. Which condition will give you a brighter or sharper or clearer picture? In a very dark room or in a very bright room? Dr. Manalili, saan mas maganda ang picture? Pag maliwanag o madilim ang room? Feel free to answer. Sige, ako muna mag-answer. Of course, diba, if you take pictures, it is more beautiful. It is brighter and clearer if you take the picture in a very bright room. Why? Take a look at this picture. Sa taas, here, this one. In a very bright room, what do you think will be the shape of your pupils? Very constricted. Why? Because your pupils should be constricted because you don't need that much light to enter. So your pupils will constrict a very small pinpoint size because it is already very bright. You don't need much of that light source to enter. And if the pupil would be very, very small in size, can you imagine the entry of these light rays? It's like a laser beam, very sharp, very acute angle. So point sources of light will enter the pupil in a very sharp, acute angle. When it reach the retina, okay, when it reach the retina, see, whether if your retina is very anterior, like this picture, itong broken line, or if your eyeball is bigger, like in the retina of this area, the broken line, which is more posterior, or normal in position or normal in shape. So whether this is anterior, middle, or posterior, that image will fall on this focal point, because a focal point, regardless if the retina is anterior, middle, or posterior, it is in the focal point. Therefore, the image is very clear. The depth of focus is very deep, malalim. Can you see this straight line? This focal point, whether here, focal point, clear vision. Anything beyond or outside the focal point, you do not have a clear vision. Okay? One analogy is like in a total eclipse, no? In totality, you only have a very limited area with totality where you can see a very clear vision or a clear image of the sun in totality na naka-obscure. So if you are, for example, if you are not in this particular area, you are not in Dallas, for example, you are outside Dallas City, you might not see a very sharp image or sharp totality of that eclipse. Why? Because you are not in that focal point. You are not in the point of that area where you will have a very sharp image, okay? Because the depth of focus in this case is very deep. Therefore, what will give you a very deep depth of focus? Pupillary constriction. Pupillary constriction or miosis. What will give you pupillary constriction? Parasympathetic stimulation. Parasympathetics will constrict the pupils. If you constrict the pupils in a very bright room, what do you think will happen? The light rays will enter in a very acute angle. It will fall in the retina. And this retina, what did I say as compared to the camera? It is an image. So the picture or the selfie that you will get is very clear. Whether you are standing in front, you are in the middle, you are at the back, malinaw ang image mo. Malinaw ang picture mo. Because the depth of focus is very deep. As compared to this figure letter B, what can you observe with this pupil? The opening is very big. Probably the patient has sympathetic overstimulation. The patient has pupillary dilation. Dilate, dilat, mydriasis, letter D. Remember that by heart. Pupillary dilation, there's mydriasis. If you have pupillary mydriasis or dilation, pupils are very large, bilog na bilog. The light rays will enter not in a very acute angle. Actually, ito, nakikita niyo the differences, very scattered. So once the scattered light rays will enter, this particular lens, okay, should bend this one, okay, and the bending of those light rays might not make the focal point on the desired retina. Baka wala pa siya sa retina, nasa vitreous humor, nandun na yung focal point mo. Therefore, if that picture will be taken in a very dark room, walang light source, pangit, di ba? Kaya tayo naglagawa ng selfie ring light because you want that picture to be clear. So if the room is very dark, what do you think will happen to the picture? It is very poor, pangit, no? The focal point might be here, but if you're standing at the back, malabo ka na. If you start standing at the front, malabo ka na. So some of your classmates, that's why when you take a class picture, graduation picture of the entire class, some people seated in the front, malabo. Some people in the middle, malinaw. Some people at the back, malabo. Because the depth of focus is very shallow. Probably yung cameraman hindi magaling. Gumamit siya ng aperture na malaki. Pag malaki yung aperture niya, ibig sabihin, your depth of focus is very shallow. So in the eye, if the pupils will be very dilated, very mydriatic, the image is very poor because the depth of focus is very shallow. And we have an experiment on this one in your physiology of the vision laboratory, wherein you have to tell us in the conference or in the written report of your findings whether you find that image to be brighter, clearer, sharper, or that image is mas malabo, blurred, darker, or fuzzy. Okay, malabo. Fuzzy is malabo, no? Okay? Actually, okay, you can do this kind of experiment when at home or anywhere else, no? If you get a piece of lens, or hindi lens, paper, get a piece of paper. For example, you have a piece of paper, you puncture a pinhole, and then you shine, kasi you don't want to look at the sun directly, you'll be blinded. So this pinhole, you direct it to the source of light, which is the sunlight, and you take a look at the focal point. Sharp. But if a very big hole, butas, malaking butas, dilated pupil, look at that image registered at the back. It is fuzzy, malabo, parang blurred, because the depth of focus with a dilated pupil is very shallow. With a constricted pinpoint pupil, it's very deep. So you can understand and appreciate the analogy of that if you try to improvise your own experiment. But of course, in your class, we'll be having that experiment. Okay, pupils and the depth of focus. I hope you can understand the concepts, because if you'll be reading the book, you might have a harder time to appreciate, I think, but I hope we can help you out. Now, we'll be talking about the different errors of refraction, EOR. Some of you, or most of you, I should say, because young pa kayo, will have myopia. When I say myopia, this is what we call nearsighted. I think some of us, your faculties or yung older, my parents, no, ninyo, might have farsightedness. Farsightedness is your hyperopia. Normal vision is emmetropia. Now, let's try to look. When I say emmetropia, where do you want that image to register? Of course, where? In the retina. So normally, it has to be registered in the retina to have a sharp image. But if you have hyperopia, farsighted, so where do you think that image is? It is way beyond the retina. It is posterior to the retina, beyond the retina. Why? Pwedeng weak na yung lens system of the eye, matanda ka na. So yung lens ng eyeballs mo, ng eye mo, hindi na nag-accommodate. So if it cannot accommodate, what will happen? Sige, I cannot have much power to bend light rays. I will bend it slowly. Pero where would it reach the focal point? Beyond the retina. So blurred ang vision. What is the treatment for this one? Do you think you can pull your eye, babanatan mo ba eyeball mo, gagawin mo pa siyang balloon to make your eyeball bigger? Of course you cannot. That's why you have to give your patient a kind of corrective lens. So for hyperopia, because of a very weak lens system, mahina ang lens system, you have to give a biconvex lens. Because this biconvex lens can do what? Can do further bending of light rays. Biconvex lenses can converge, can bend light rays, okay, further. So hyperopia or farsighted, the vision or the image is blurred because the image is registered beyond the retina. Why? Maybe you have a very short eyeball, like this picture, or maybe you are old and your lens cannot accommodate. You have a very weak lens system, so you have to give your biconvex lenses, because biconvex lenses can further converge light rays. Now, most of us, I am myopic, like super mega myopic, 550, which is minus 5.5 diopter. Because farsightedness, hyperopia, is given the plus sign. Myopia or nearsightedness is given a minus sign, negative. Okay? So when I am myopic, I have two reasons. Maybe the lens system of my eye is too strong. Masyadong malakas, galit na galit ang lens of my eye. It will bend the light rays. If you bend the light rays na galit, too much bending of the light rays, where will the image fall? Anterior to the retina. If it will fall anterior to the retina, you'll have a very fuzzy or blurred image. Another reason, your eyeball is too big. Malaki, mahaba. So your retina mo is here, but it is too long. So your image will fall here. That's the reason why some children or some babies, have you noticed that? At 1 year old, ay hindi naman 1 year old, kawawa naman. At 4 year old, for example, he's wearing a -1 diopter, malabo ang mata. Pansin mo, after 1 year, repeat checkup ng mata, -2 na. After 1 year, -3 na. Why? Because that baby is growing. And if you grow, it is not just the bones that are enlarging or elongating, including the soft tissues. And the eyeball is an example of soft tissue, and they can grow. So lumalaki siya. So enlarging eyeball or elongating eyeballs can make a person prone to have myopia. So one of the treatments is you have to correct the vision. But of course, are you brutal enough to, okay, halika, patient, come here, myopic, you have too long of an eyeball, I'll cut your eyeball. That's not possible. You cannot do that. So one treatment is you give the patient a corrective lens. How can you give a corrective lens? You give a biconcave lens. Biconcave lens can diverge the light rays first, and then when it reaches the lens, it will converge. Another treatment is they can do, narinig niyo ba yung LASIK procedure? So, what did I say earlier? The cornea is a very powerful refractive medium. So you can rub. So kung parang ginaganyan nila, parang kinikis-kis, no? They will do certain maneuvers on the cornea to lessen the refractive power so as the image will fall more posteriorly and reach the retina, which is the desired area where the focal point should be. So now we have discussed errors of refraction, emmetropia, normal, hyperopia, farsighted, biconvex lens, too short of an eyeball, too weak of a lens system, or myopia, which is your nearsightedness, can be due to a very strong lens system of the eye, too long of an eyeball. So you give your patient with a biconcave lens. Another error of refraction, which you will also see in the chart. I will not tell you what do you call the chart because it is in the laboratory. You have to report it to us. In the chart, you do not just see letters, numbers, colors. You will see a picture like that one. Yung mga rays, no, black rays. Some patients with astigmatism, they might have a perception that at this particular angle, at this particular degree, this is sharper, this is darker, lighter, because they have an error of refraction or what we call your astigmatism. Astigmatism, they might have a different perception of the sharpness of an image at different degrees or at different angles. I told you for hyperopia and myopia, you correct them with your biconcave and biconvex lenses. And those two examples of lenses are your spherical lenses. But for astigmatism, you correct this error of refraction with a cylindrical lens. You remember that, with a cylindrical lens. Some patients opt not to use eyeglasses. They would like to use contact lenses because they want to change the color of the eye from aqua blue to emerald green or whatever. Okay? So aquamarine, amethyst, or kung ano man meron sa market. But it's fun. But some people would like to use contact lenses not just because they want to change the colors of the eye. They might have keratoconus. When I say keratoconus, cone-shaped yung cornea. You have an abnormal shaped cornea. So, can you imagine a baseball or yung basketball? Di ba bilog siya? So if you imagine, this is round, your eyeball, but the cornea is irregular in shape, cone shape. Hindi siya pantay, no? So if you have keratoconus, one part of your cornea is more bulged than the other. So you might have different grade. Iba-iba yung grado mo, no? Baka when you look at the upper part, you'll have clear vision. When you look at the lower part, the visual field is very blurred. So patients with keratoconus, they usually will be asked to wear contact lenses because that contact lenses can somehow flatten out or can correct that irregularly shaped cornea. Another advantage of wearing your contact lenses is about the visual field. When I say visual field, from now on, it is the part na nakikita ninyo, the part that you can see. So this is my eyeball. This area that I can see would be the visual field. When I am wearing my contact lenses, which is a -5 diopter, so when I look straight, clear. When I look to the right, clear. When I look to the left, clear. Or anywhere else, clear. Why? Because the contact lenses is floating on top of the cornea. When I move my eyeball up, down, left, right, 360 degree, clear pa din yung vision because the contact lens can follow the eyeball. So 360, you'll have a very sharp visual field as compared to wearing spectacles or eyeglasses, especially mga cat eye or yung mga maliliit na shape ang frame. If I'm wearing eyeglasses, this is the frame, maliit. When I look straight, clear ang vision. When I look up, blurred na yung vision. When I look to the right, blurred yung vision. Because you do not have a 360-degree coverage for you to have a clear vision. Next, size of the objects. Some of you who are very keen or very curious, or if it piques your interest, I think, no, you try it. Yung mga naka-eyeglasses, try ninyo. When you are wearing eyeglasses, if that lens is farther away from your eye, mas malayo from your eye, the image that you can see would be smaller. When it is nearer to your eye, the object that you can see is bigger, but I cannot say that it is the same actual size because wearing eyeglasses, because that lens is not a part of your eye, it is not inherently sa mata ninyo, so you cannot perceive the actual size of the object. If you are wearing your spectacles, it will almost always be smaller, so you cannot appreciate the actual size of the objects. That's why you want to see your things clearly in its actual shape. So you can wear your contact lenses, diba? Malakas na yung malaki na yung visual field mo, clear pa yung vision mo, iba-iba yung pangkulay ng mata mo any day you like. You're at a whim, you can change, okay? So some patients with cataract, for cosmetic reasons, ano ito sa Tagalog? Ano yung isda na namamatay na? I forgot yung fish na gray na yung mata, yung parang cloudy na yung eye. Bilasa, yes, bilasa na isda, no? If you can see, that's the eye that you can see among your patients with cataracts, no? Parang bilasa na isda, yung parang very cloudy. So some patients ayaw magpa-opera, or some patients who are victims of trauma, sabihin natin, tinusok siya ng kapitbahay na ng lapis. I have a classmate na ganun before sa physical therapy days ko. Alam mo bakit? Natapon ng muriatic acid. So, ay nako, I don't know why. So, natapon siya ng muriatic acid. So, permanently damaged, no? So, you can always see a scar. Ayaw na may scar sa eye niya. So, he wears contact lenses para hindi nakikita yung scar. May kulay ng mata, maganda pa. Okay? So, I hope you can understand. Why do you think the eye of a patient, especially older, will have cataract? Because the cataract is a problem where? Is it a problem of the cornea? It is not. Is it a problem of the retina? It is not. Look at this picture. A normal lens is said to be crystalline in nature, very transparent. Okay, imagine a piece of gemstone, class A gemstone, as in very high clarity, internally flawless. As in, wala kang makikitang inclusions like this one, a normal lens. Pagpasok nung ray of light, pasok hanggang sa retina, you'll have a very sharp image. As compared to this piece of lens, for example, matanda na, or as compared to a gemstone, kanina pa ako gemstone, but it's a very nice analogy. A piece of an included diamond, or if we have a paraiba tourmaline na included, pangit ang kalidad, ang quality. So very opaque. So the terminology or the jargon that we'll use now is opacity, okay? This one has a very clear opacity or very transparent. This one has a very high opacity or very opaque. Okay, so light cannot pass through. This is a clouded lens. So as you grow older, there will be buildup of proteinaceous substances. If you have diabetes, you have buildup of sorbitol, yung mga waste products, okay? So you'll have a very clouded lens. And that can be one of the reasons why you have blurring of vision because of a cataract. And with cataract, of course, you have to undergo phacoemulsification. So you have to emulsify, you have to melt, you have to suck out that lens and replace it with a new lens. Because one of the complications of a cataract is not just blurring of vision. You can have a buildup of pressure, you'll have glaucoma, and eventually the grave complication is you might have blindness because of a cataract leading to glaucoma and to a permanent damage to the eye. And that is one of the things that we don't want that to happen, okay? So we're talking about the opacity of the lens. When you're younger, physiologically, it is very crystalline. If you read your Guyton, the lens is described as the word crystalline. But when you grow older, it is very opaque. Okay? Clear? Okay. Visual acuity. When I say visual acuity, I'm talking about how sharp the image is going to be. In visual acuity, I will not discuss this very much in detail. Why? Because I want you to read on that, because you have a part of the experiment about the visual acuity. What do you call the chart that you use? But I want you to know the part of the retina, because that image will fall in the retina. And the part of the retina with the highest visual acuity is a fovea, particularly the fovea centralis. In the next few slides, I will tell you why. Bakit hindi sa periphery? Bakit kailangan sa fovea? I'll let you know the reason why. Let's try to talk about 20/20 versus 20/200. This is a visual acuity, kung gaano kalinaw yung vision. Now, a 20/20 vision is said to be a normal visual acuity. 20/200 is a very poor visual acuity. I will not discuss this further because this will be part of your experiment, and I want you to read on this one in your textbook, okay? Or whatever sources that you want to read. But Guyton is a very good book. He's a very good neurologist, and you have to read on the visual acuity for sure, because I want you to know, if the denominator is higher, what do you think is a visual acuity? Is it inversely proportional or directly proportional? Mas mataas yung denominator, mas malinaw ba o mas malabo yung vision ko? And what do I mean by that 20 numerator? What is the 20 denominator? I am sure I will ask that in the exam, but I want you to read on that interpretation, kung bakit. Okay? Now, wait lang. Depth perception. Gano kalalim, gano kalayo? Because there are certain ways on how I can tell the relative or the approximate distance from me and that particular object. Depth perception. How? First, the size of retinal images of known object. First, you have to know the actual size of the object or person. Okay, I know maraming mga Swiftie fans sa inyo, yung manonood ng Taylor Swift or whatever. You know her height. You know she is tall. You know she is 5'11" tall. So whether you went to Singapore and you were seated in front of that arena, you will see that Taylor Swift appears bigger, taller. But when you are seated at the back, pinakalikod, wala ka daw kasi nabiling ticket in the bidding, we're seated at the back, you can see that Taylor Swift appears smaller. But you know that you are farther away. Why? Because you know the size of that object. You know the height of that person, that she's 5'11" tall. So you know that you are nearer to her because she appears to be bigger, mas malapit ka. But when you are seated farther away, she looks smaller, and you know in your brain that you are farther away. So you can tell the relative distance, the approximate distance, whether you are nearer or farther away from that person or object. It's because you have to know the actual size of that object or person. Next, moving parallax. With moving parallax, you do not know ano ba yung size ng object. Do you know what is the size of the moon? Hindi. Do you know what is the size of the sun? I think it's in the textbooks, no? Ng mga science books, but of course I do not memorize those. Okay, let's try to do a drill, no? Magbe-break na tayo in a while. Moving parallax. Everybody, you use your left index finger, put it in front, well, look at a window muna. Kung may window kayo in the room, look at the window and focus your vision or sight at a distant or malayo na object or scenery. For example, I can see here the lamppost, okay? So if this is my index finger of the left hand, put it in front of you, roughly around 1 foot in front of you, and then you can see that lamppost or a distant object outside your window. Now, you try to move left yung head. Left, right, left, right, left, right. Which one appears to be moving? Yung finger mo ba ang mukhang gumagalaw o yung distant object? The theory or the principle of moving parallax states that nearer objects appear to be moving, while farther or distant objects appear to be stationary or hindi gumagalaw. So at least if you know, ay, itong object, itong kamay ko, finger ko, mukha siyang gumagalaw. Because the finger is nearer to you, it's just 1 foot in front of you. But that lamppost is 10, 20 meters in front of me. So I know the relative distance. Ay, mas malapit ako dito sa fingertip ko kaysa dun sa lamppost. Because this is a principle of moving parallax. Another example where you can appreciate this one is if we are doing a road trip or if you are in a plane, nasa airplane ka, you're looking, nasa window seat ka, you're looking outside the window, you can see the moon. You can see the clouds. Ay, yung clouds appear to be moving. Parang nag-drift, parang gumagalaw yung clouds. But the moon nandyan lang. Why? Because the moon, you know, is farther away. And the clouds is mas malapit. So you can tell the depth perception that the clouds appear to be nearer because they are really nearer, because they appear to be moving. And the stationary thing na mas hindi gumagalaw is a farther away na object. Okay? You can also do this analogy or drill when you're doing a road trip. You look at the window. Okay? If you are at the passenger seat, you look, which I am favorite na position ko. No? Gusto ko sa passenger seat because I cannot drive. So the passenger seat, when I look out the window at the side, road trip, ay, bakit yung for example, yung mga evergreens, yung mga trees, parang gumagalaw. Pero yung mountain top, yung may glacier, ay bakit parang stationary? Because I know that my distance from me to that glacier is farther away and it appears to be stationary. And these trees, yung mga evergreen trees, they are appearing to be moving. That is a moving parallax. Lastly, stereopsis. Stereopsis is called your binocular vision. Some patients, okay, who have, sabihin natin, trauma or neuroblastoma, blind, isa lang yung at mata. If you have only one eye, monocular vision, you cannot appreciate depth. You cannot appreciate stereopsis because stereopsis is only applicable if you have binocular vision because your right eye can see this particular visual field. This left eye can see this visual field. So the left eye can see the lateral part of the left visual field. My right eye can see the lateral part of the right visual field, but hindi niya nakikita yung nasa lateral part of the left eye. So if you have two intact eyes, you can have depth perception by binocular vision. the right eye's visual field plus the left eye's visual field, there's what you call the fusion of the image. So you'll have a 360, so parang 300, kumbaga parang 3D, three-dimensional view of that surrounding. So depth perception with stereopsis is very important when, if you're doing, sabi natin, mountain climbing, if you're descending down from the stairs, you're climbing a mountain, Mount Everest, you're climbing up, and then pababa ka na from the Mount Everest. Ala, isa lang yung intact na mata ko. I cannot tell itong inaapakan ko ba is pantay or not because there's no stereopsis. You can tend to fall down the stairs. You can tend to fall down the cliff and die in Mount Everest if you do not have binocular vision. There's no fusion of image. Some patients with strabismus, yung mga naduduling o nababanlag, one eye is straight, one eye is deviated to the other side, to the left side. So there might not be a fusion of image. So there can be a very poor depth perception. Okay? I can see some questions at chat box, pero mamaya ko na i-read during the break. Okay? So intraocular fluid now, remember, let's try to look at this cross-section again. We have talked about the cornea, we have talked about the lens, we have talked about the ciliary muscles, we have talked about the the suspensory ligaments. Now let's talk about the fluid component. So you have two fluid components of the eye. The anterior, take note, anterior, letter A, anterior A. The anterior chamber, or the part, is what you call the aqueous humor containing chamber. Anterior, letter A. Anterior aqueous humor, letter A. Di ba madali lang? So, syempre, if you have the anterior, you have the posterior. The posterior component or the compartment is made up of a vitreous humor. My next question is, which one is more viscous? When I say viscous, mas viscid, mas malapot, mas gel-like in consistency. I think I've told you that earlier. The vitreous humor is gel-like in consistency, and those two fluid chambers can give the globular shape of your eyeball to maintain a normal intraocular pressure. The vitreous humor is said to be more viscid. Ang mnemonics mo dyan, viscid, viscous, vitreous humor. Ang nasa anterior is the aqueous humor, anterior letter A. Anterior humor is more watery, vitreous humor is more viscous or more viscid. Vitreous humor. Same is true, just like the cerebrospinal fluid, which is from the capillaries, okay? An ultrafiltrate of the blood, very sterile. Your intraocular fluid from the aqueous and the vitreous humor, see, the aqueous humor, they are produced by the ciliary processes, okay? To the point that the aqueous humor, look at this picture. See, parang siyang blood, okay? Blood veins. My next question is, look at these aqueous veins. Why are they not blue? Diba in Netter or in the atlases that you use, blood is usually, it's either arterial, red in color, blue or violet in the atlases if they are venous. Look at this one. How come the aqueous veins, which are very important in the absorption of your aqueous humor, bakit transparent? Why? Because it is said that the aqueous veins, although they are veins, mostly they would contain the aqueous humor, because the aqueous humor will be drained through the canal, and this canal is called the canal of Schlemm. Canal of Schlemm, okay? Into the aqueous vein and into the veins of the eye, into the ophthalmic vein, etc. You'll learn those in anatomy. Okay? Therefore, I'll ask you, production of your aqueous humor or the fluid of your eye would be from the ciliary processes. Drainage would be through the trabeculae, and they would drain to where? The canal of Schlemm. What did I tell you before in higher center about the cerebrospinal fluid? Anything produced should be drained. Because why? You want to achieve equilibrium. If we produce this amount of aqueous humor, this particular amount should be turned over and drained through the canal of Schlemm. Some patients might have a too much production of the aqueous humor, which can lead to increase in the intraocular pressure. You can have glaucoma. Some patients might have a normal production of aqueous humor. However, there's a blockade in the canal of Schlemm na bara. If you block the canal of Schlemm, what conditions will give you a blockade in the canal of Schlemm? Infection. Who knows? You have an eye infection, bacterial debris after phagocytosis. Nagkaroon ka ng mga muta, you have pus, you have bacterial debris that can block the drainage of your aqueous humor, which can block the canal of Schlemm. You might have a normal production of aqueous humor, but you have impaired drainage. So you have stenosis, anatomically makipot, or you have a very stenotic or very narrow opening in the canal of Schlemm. Then you can also have increase in pressure. And increase in pressure, one of the dreaded complications would be glaucoma. And glaucoma is said to be an emergency ophthalmological wise, and also as an internal medicine practitioner. Look, I have seen patients with a very high blood pressure. Hindi lahat ng high blood pressure is bibigyan mo lang ng medications to lower down the blood pressure. You have to investigate. History taking. Do you have blurring of vision? Do you have pain in your eye? If your patient will tell, Dok, ang taas ang blood pressure ko, 250 out over 120. You ask your patient, do you have blurring of vision? Do you have pain in your eye? Physical examination, you open the eye, ang pula-pula. And you touch the eye, you palpate, ang sakit, very tender, because there is already a medical emergency. There's buildup of aqueous humor, an increase in intraocular pressure. The patient can have glaucoma. Just very recently before I flew, noong March, I just admitted my aunt. Her daughter called me, ay Doc, admit natin si auntie kasi because she has vomiting, she has headache. So I said, okay, I think I know your history. You have a previous history of cataract na hindi pa nag-undergo ng surgery. So I said, admit, this is an emergency. It's not just because you are vomiting, I want to admit you. It is not that because I want you to be admitted lang. Hindi yung parang gusto ko ma-admit ka lang. Admit, no. By history, you ask, high blood pressure, you increase the blood pressure, there's pain. And when you ask the patient, blurring vision, ang pula-pula, ang sakit, there's pain in the eye. When I palpated the eye, very tender, very painful, very red. True enough, I referred her to the ophthalmologist, and she had an acute glaucoma, which can lead to blindness, if not reversed. Okay, so that 2 days after she underwent operation, the day after I discharged her. So wala pang 1 week, if you can pinpoint the cause, then you can treat your patients well. I think glaucoma might be just minor if you think, no? Mata lang yan, but it's not. Permanent blindness can happen, and we don't want that to happen. It's hard. You cannot see the wonder of nature, okay? So the intraocular pressure can be measured by what we call the tonometry. Tonometer is that machine. I'm not a practicing ophthalmologist, so hindi ako magmamagaling on how you do this, no? But I've seen my mother, my aunt in their clinics when they do checkups sa ophtha nila, how they do that. And na-try ko rin. It's not painful because they drop anesthetics into the eye, so you won't see the plunger push into your eye to check for the pressure. Hindi naman masakit. So glaucoma is one of the complications which can lead to blindness. The normal intraocular pressure is 15 millimeter mercury, average range of 12 to 20 millimeter mercury. Okay, so let's resume. Okay, so now we'll go to the second part, which is the retina. We have already finished optics, so second part. When you talk about your retina, so this will be the start of the neuro part, okay, of your vision. You will see that you have so many layers of the retina, but of course I will not ask you to memorize what is a layer, what is a lining epithelium, which one in chronological order, because this is not anatomy class, this is not histology class, so I will not ask you that. But there will be certain principles that you have to know by heart. Very important. The receptors for your vision would be the cones and the rods. Rods and the cones. Tingnan natin, no? So we have the pigmented layer, outer nuclear, outer plexiform, inner nuclear, inner plexiform, ganglion cell, etc. Very important, later on, we'll talk about the ganglion cell. We'll talk about a little bit about the pigmented layer, and of course, the rods and the cones. Okay, so if I'm going to enlarge the image, this is the rod and this is the cone. As a shape will tell us, cone shape is a cone, cylindrical shape is a rod. So in microscopic view, makikita mo, you'll see the outer segment, the inner segment. Okay, very important. I'll discuss these two later. Why? Okay, take a look. What did I tell you about the fovea? Fovea is a part of the retina with the highest visual acuity, particularly which part of the fovea, which is just 0.3 millimeter in diameter, Maliit lang siya. It is a central fovea. Now, what do you think would be the reason why in the fovea or the central fovea you have a very sharp visual acuity? If you can see, the retina is composed of so many layers. But in this picture here, in the fovea centralis, most of the layers are thinned out, mas manipis, because they are curtained. Nahawi siya to one side. So if this is a peripheral part of the retina, and this is a fovea centralis, you have a thinner layers in the fovea centralis. That's why if you have thinner or fewer layers, what will happen? Light will pass through easily, mas madali, as compared to the periphery. That is the reason why the fovea has a sharper or better visual acuity. That is one reason, because we have two. First reason is you have thinner or lesser layers of the retina. The second reason I'll tell you in a while, so stay tuned. So when I talk about the photoreceptors, I'm talking about the rods and the cones. I also told you that we'll be saying something important about the pigment layer. The pigment layer is because of what? The melanin, the black pigment. The melanin is very important. Why? Because it would prevent what? Stimulation of all rods and cones. Imagine, if you are an albino, wala kang melanin, you do not have pigment. If you go out to a very bright room, for example, during a bright summer day in the beach, relaxing. If you are an albino, you do not have melanin. You go out to the beach, you look at the sun, you look at the environment, silaw na silaw ka. The glare of the sun will make you very, very uncomfortable. Why? Because the glare of the sun cannot be absorbed by the pigment layer. That sunlight, excess sunlight, cannot be absorbed by the pigment layer. Because if you have the pigment layer, it would absorb most of the light, and it is only the part of the retina that you want to be stimulated will be stimulated. So if you want to just stimulate a few of the rods and cones, only a few of them would be stimulated. But if you do not have melanin, it cannot block out. Hindi na ma-block out, hindi na ma-absorb the excess light rays. So the light rays will go inside your eye, it would stimulate all of the rods and cones. Imagine if you stimulate all of the rods and cones, lahat yan stimulated, silaw na silaw ka, you have glare. So excessive glare. So that's the fallback of patients with albinism. They do not have the pigment layer. When you do a fundoscopic exam, you look into their eye, what can you see? You can see the blood vessels. They look like the eyes of rabbits. You can see the blood vessels. In fact, they're really color pink. You might have contact lenses that are color pink that are beautiful, but if you are really an albino, you do not have the pigment layer, it is not advisable that you go out in the sun without any protections. You can have blindness, okay? We will talk about vitamin A later on. But what can you remember in your health science classes when you were younger in your elementary days? What will your teacher tell you? We need vitamin A to prevent night blindness, period. So what is the reason behind that? They did not explain to us. But later on, you will know. Okay? The central retinal artery is a main artery that would innervate or would supply oxygenation, nutrients, and blood supply to the inner part of your retina. That's why if you have a retinal detachment, for example, you had a wrestling fight, WrestleMania, you had a wrestling fight, and then you were suplex, untog ka, and then there's a sudden tear, napunit yung retina. If this would be managed or treated accordingly in a very short window period, let's say within a day or two, you can still recover, okay? Because you have the choroid. This choroid can give you temporary blood supply, but it is a central retinal artery that is the most important. So if there's a retinal detachment and it is not addressed properly, you can have permanent blindness, okay? Here, you have to look at this picture. You do not have to memorize because I do not really recommend you to memorize. I want you to understand what will happen. If I'll shine a light on your eye, what's happening? What will be the chemical processes or physiologic processes that are happening? So we take a look at this one. The rhodopsin is also known as a visual purple. Okay, rhodopsin, letter R, rhodos, rod, sounds like rods. So rhodopsin for your rods. What are rods for? Black and white vision. Rhodopsin, rods. Rods are for your black and white vision. Cones, letter C, cone, color, chromato, color. So cone pigments are for your color vision. So take a look at this one. Your rhodopsin here is a parent cell. So it is the visual purple. Other name is a visual purple, rhodopsin. If there's light energy na silawan, or you see an object, you can see that object because that object is emitting light rays. So if there's light energy, this rhodopsin will undergo a series of chemical processes, steps, a cascade. Beta-rhodopsin would be broken down into your Lumiere rhodopsin. Meta-rhodopsin 1 becomes a meta-rhodopsin 2, and then this meta-rhodopsin 2 will be broken down into two substances, two substrates, your scotopsin and the retinal, okay, and the retinal. But remember, your rhodopsin can be depleted, nauubos yan. But the scotopsin should be able to bind to a particular form of retinal, which is 11-cis retinal. If the meta-rhodopsin will produce the all-trans retinal, even though this is a retinal, it is not 11-cis retinal. So the all-trans retinal, you have to know this, the all-trans retinal cannot bind to your scotopsin to become the rhodopsin. It has to be converted to the 11-cis retinal. So this step should make use of the enzyme isomerase. This enzyme isomerase will convert all trans retinal to 11-cis retinal. This 11-cis retinal will plus scotopsin to become your rhodopsin again. So this cycle goes on and on and on. So we should have enough or ample supply of your rhodopsin for us to be able to appreciate black and white vision. When I say black and white vision, hindi lang literally black and white. So rhodopsin are very important for night vision. So if you are in the movie house, if you're in a total solar eclipse, mukhang nighttime, or if you're leaving the high Arctic during deep twilight, walang daytime for almost half a year. So your rhodopsin will be very, very important for your black and white vision, night vision. So this is one step. The breaking down of your meta-rhodopsin to become all-trans retinal, and the conversion of all-trans retinal to become 11-cis retinal, which should combine with your scotopsin to give you rhodopsin. However, we are so blessed because in our body, we have the metabolism of your vitamin A. And your all-trans retinol is a form of your vitamin A. Therefore, it is said we should have enough vitamin A in our diet because this vitamin A from your diet, this all-trans retinol can be an alternative step. So this metarhodopsin can be converted to all-trans retinol plus scotop to become 11-cis retinol to become scotopsin, and this vitamin A can be a contributory source, okay, of your 11-cis retinol, because the all-trans retinol can vice versa become your all-trans retinol, and this all-trans retinol also using the same enzyme, the isomerase, to be converted to 11-cis retinol, and this is also vice versa. Baliktaran, no? So this 11-cis retinol can give you the 11-cis retinol and vice versa, and so you have more vitamin A, you have more chances to have 11-cis retinol, and you have more 11-cis retinol, you can have more substrate to combine with your scotopsin to become your rhodopsin. Therefore, if you are living the high Arctic, if you are living in high Alaska or in remote Alaska, for example, or in northern Sweden, in the Lapland, in Svalbard, northern Norway, Greenland, or in Antarctica and the lower hemispheres naman, extreme polar regions. If you do not have enough supply of your vitamin A in your diet, you can have night blindness. Why? Because vitamin A in the form of your all-trans retinol can serve as an additional substrate for the production of your 11-cis retinol to combine with scotopsin to give you your rhodopsin. So if you go back to your elementary days, vitamin A is important to prevent night blindness. Why? And it is because of this step. It can serve as an additional substrate. Do you follow? Yes. Now, excitation of the rod, it is said to be a hyperpolarizing change. Okay, if you remember the basics in physiology, when there is a stimulation, there is depolarization. There's a depolarizing change. But excitation of the rods, even the cones actually, excitation of the rods and cones is said to be hyperpolarizing. When I say hyperpolarizing, it becomes more positive or more negative inside the cell. It becomes more, mas nag-negative siya. Because if depolarization, you make inside the cell to be what? If you recall physiology A, if you depolarize, you make the cell to be more positive or less negative. Okay? So clear yan, na? However, in excitation of the rods, there's a hyperpolarizing change. I want you to know why. Hindi lang siya because it is written in the textbook. There's always a rational why. That's why this is physiology class. This is example of rod. Outer segment, inner segment. Let's take a look at the inner segment. Of course, this is a cell. You have the sodium-potassium ATPase. The sodium-potassium ATPase will continuously pump out sodium. Potassium will come in. So 3 sodium out, 2 potassium in. Normal physiologic resting membrane potential. I'm pretty sure we all know that. However, in the outer segment, the sodium, tingnan mo, kakaiba siya. The sodium can freely go inside the cell. Why? Because you have the cyclic GMP gated channels. The cyclic GMP gated channels in a resting. When I say resting, it is a dark phase. Walang simulation, dark, madilim. In a resting dark stage, the cyclic GMP gated channels are open. If they're open, so you have a very high cyclic GMP, mataas in the dark phase, the sodium can freely go inside. So sodium can go inside, can leak inside. Hindi nga siya nagli-leak lang eh. As in the door is talagang open for the sodium ions to go inside. Therefore, in a resting, non-stimulated rod and cone, in a dark phase, madilim, you have high cyclic GMP. If you have high cyclic GMP, you open the gated channels. If you open the gated channels, sodium can go inside freely, making the cell less negative as compared to other cells. That's why in the resting membrane, it is minus 40 millivolt inside. What is the charge of the skeletal muscle? Minus 90 pag resting. But in the rods and cones, minus 40 millivolts. However, in the presence of light, there's stimulation. The sodium cannot go inside. Why? Because in the presence of light, in the presence of stimulation, the cyclic GMP goes down. How does it go down? I'll show you in the next slide. The cyclic GMP goes down. The channels, the gated channels will close. If you close the channel, can the sodium go inside? No. The ions cannot go inside. Therefore, if there's stimulation, sodium ion cannot go inside. You make inside the cell to be more negative. That's why stimulation of the rods and cones is said to be a hyperpolarizing change. You make the charge inside the cell to be more negative. This picture will show you an enlarged picture of the previous one. The outer segment, I told you, in a resting stage, the sodium can go inside. Assuming this is resting, do not take a look at this light. Wala pang light source. Normal lang. Rhodopsin, G-protein transducin, walang phosphodiesterase that will destroy the cyclic GMP. Wala yan. Walang ganap na ganyan. Walang ganap na ganon. So resting phase, the sodium can go inside because the cyclic GMP is high. The cyclic GMP is high, therefore the gated sodium channels are open. Sodium can go inside, making the membrane minus 40, less negative. Now, there's stimulation, there's light source. The rhodopsin will be broken down into the metarhodopsin, bathorodopsin, lumirhodopsin, metarhodopsin 1, metarhodopsin 2. And then what will happen? Biochemistry-wise, okay? So this G-protein transducin would make the cyclic GMP phosphodiesterase. So itong phosphodiesterase, an enzyme, will destroy the cyclic GMP. When you destroy the cyclic GMP, you lower down the cyclic GMP, you increase the 5' GMP. Because when the cyclic GMP is broken down by the phosphodiesterase enzyme, it will yield 5' GMP. So if there's light source, you lower down the cyclic GMP because of an activity of the phosphodiesterase, and this phosphodiesterase enzyme will destroy the cyclic GMP. Lowering the cyclic GMP will increase the 5' GMP. Increasing the 5' GMP will shut the channel close. Sodium cannot go inside. Therefore, it is a hyperpolarizing change. It becomes even more negative if there's stimulation. I hope you follow and understand me. Okay? Next, same is true with the color cones. So same lang siya with the rods. Now, excitation of the cones, okay? So photopsins ang usapan, color pigments, cones, okay? Photopsins, what do I say? The retinal portion is the same. Remember, I showed you this one. Rhodopsin, or the visual purple, is made up of the scotopsin and the retinal. For cones, the cone pigments will be made up of the photopsin. So photopsin is a component of the cone pigment, while scotopsin is a component of your rod. Do you follow? So cone pigment is made up of your photopsin plus retinal. Your black and white vision, your rhodopsin is made up of the scotopsin plus the retinal. Clear yan na? Rhodopsin, scotopsin plus retinal. Photopsin is color pigment. So color pigment will be photopsin plus the retinal. Photopsin, color. Scotopsin, black and white. Okay? We are able to perceive colors is because we have three types of cones, rather. We have the blue, the green, and the red. So in a spectroscopy, you can see the wavelength. We call that the spectroscope, okay? You can see the wavelength of the colors. I think you have seen a spectroscope when you are doing the drill in your hematology. And did you know that gemologists, they also make use of the spectroscope? They can put an unknown gemstone into a spectroscope and they can peek through the hole. And if there's absorption of certain wavelength, for example, a garnet, there's absorption of the yellow and the orange waveform. So if you can see that, you can differentiate it from a ruby, or the nice piece of information, because both of them are color red. There's always a differentiation to help you lock in your unknown. Ano siya. So also in the eye, we have the three types of cones. So if this is the spectroscope, you can see the wavelength, okay, of the colors. The red is the infrared, or it has a longest wavelength. The blue and the purples will be the shorter wavelength. Okay? So I'll tell you later on how to stimulate them. Okay? Pero nice to know. At least you know how it works. So siya si Lumiere, wala lang segue. Cute lang siya. Okay? So the rods and cones are also very important, not just because they enable us to see objects. They enable us to see in the dark and the light. There's what we call the adaptation. This is very important. When I was younger, siguro tayo, no? When you go to the movie house, sabi na, ay, dilim-dilim. Like, it's so dark, I cannot see. When you go out to the movie house, it's so bright, I cannot see clearly. It is because the rods and cones are, functioning quite well. How? So when I talk about the dark and light adaptation, we always remember of the photosensitive cells. They are the major players. Silang bida. So the photosensitive cells, we have the rods and the cones. What did I tell you earlier? Rods are for black and white vision, night vision. Cones are for your color vision, daytime vision. Because in daytime, we can appreciate colors. So we need the cones. At nighttime, we cannot appreciate much of those colors. Why? Because it is not the cones who are acting. It's more of the rods. In this chart, or in this graph rather, you will know why. Bakit sa dark rods lang? Take a look. The X and Y axis, okay? Here, you have 0 minutes in the dark, meaning to say you just entered the very dark room. You just entered the movie house. Once you enter into a movie house, labo, madilim, I cannot find my chair. It is because the cones are adapting. So if I talk about the speed, which one will adapt quickly? Sino mas unang mag-adapt, si cones or si rods? The cones. The cones will adapt quickly. However, in a matter of around 5 minutes, 8 minutes, they will stop adapting. However, the rods are more sensitive, even beyond 10 minutes, beyond 15 minutes, or forever and ever. You are in the movie house for 3 hours because you are watching Titanic for 3 hours. The entire movie, the entire 3 hours, you are able to see your seatmate, you are able to get your popcorn and eat your popcorn, you are able to see that chair is occupied or not because the rods are adapting. The rods are very important for dark vision. Therefore, cones, color, they are very fast, speedy. Speed-wise, sila nauuna mag-adapt. But sensitivity-wise, the cone would have a very low sensitivity because prolonged exposure in the dark, it will be the rods that will be playing their role, okay? Of course, the size of the pupils will have a role, the constriction and the dilation, and neural adaptation. But of course, when you talk about light and dark adaptation, the retina, the major players will be the rods and cones. So I want you to know that. Speed, mas mabilis, color, cone. Mas highly sensitive si rods, black and white vision, dark vision, night vision. So what do you think is the value of adaptation? Whether we are in a bright sunlight, in a midnight sun, never-ending summer, sunlight, very important. You have your color vision. You appreciate the trees. You appreciate the Arctic Ocean. You appreciate each and every view. However, in dark starlight, in deep twilight, in polar night, no sunlight, 60 days of night, not much function of your cones ang makikita mo. But you will see rods. You'll see entirety na medyo madilim, not much color vision because the rods would play their major role. So in bright sunlight or yung very dim starlight, you should have your dark and light adaptation. Also, there's what we call the Purkinje effect. Nice to know, the Purkinje effect. Parang yung Purkinje cells of your heart. The Purkinje effect, it is said that it was actually noticed by a physiologist, a Czech Republican physiologist named Purkinje. No? So they call it the Purkinje effect. In dark period, you see things that are kind of parang very mossy, dark, blurry, grayish, sepia tone, madilim, not much color. But at bright time, daytime, you can see that the flower is red, the flower is orange. That's what we call the Purkinje effect, because the opposite happens. So Dr. Purkinje noted when he was outside in the garden in the bright sunlight na umaga, he can see that the flowers are red, that the leaves are green, and then when dusk would come, dapit hapon na, no, sunset, twilight, he noticed that that red flower slowly turns darker in color, parang grayish tone, di mo na siya nakikita. However, those greenish, the dark colored hues, parang mas nakikita na sa gabi. That is a Purkinje effect. It is because of the rods and cones. Because at night, it is the rods that will play their role. In daytime, it is a cone. And it is a cone, of course, you can see color vision. You'll see more vivid colors. You'll see the beauty of the red ruby. You'll see the beauty of the blue paraiba, etc. Okay? So that's a light and dark adaptation, the Purkinje effect. And that is also the reason why they say that during a total solar eclipse, if we want to appreciate the change in the environment, you have to wear red and green for you to appreciate the Purkinje effect. Because at total solar eclipse, at the totality, sobrang dilim, rod vision. But at daylight, unti-unti pa lang nawawala yung sun. Your cones are still stimulated. But when the sun is almost 70% obscured by the moon, the sensitivity of the cones will decrease and the sensitivity of the rods will increase. So you see more of those surroundings. Ay, parang mas nakikita nyo yung dark colors of the green grass. Mas hindi ko na na-appreciate yung mga butterflies, the bright red and yellow. Purkinje effect, the rods and the cones. I hope you follow. Now, the color vision, the reason why you can interpret colors, because we only have three cones. We have the red, green, and the blue. We do not have magenta, you do not have fuchsia, you do not have orange. However, how can we determine color interpretation? For example, if this is the spectrum of the color from blue to red, so the shortest wavelength to the longest wavelength, which is red, infrared, diba? I can appreciate orange because at 508, sabi natin orange, mandarin orange, it will fall at 580 nanometer. So it's somehow here, 580 nanometer. Oh, I can appreciate orange because I stimulate 99% of my blue, I stimulate 40% of my green, and sabi natin none of my red, something like that. I can appreciate this 450 nanometer blue. Maybe this is aquamarine blue because I stimulate 97% of my green, a little bit of my blue. So it's always an interplay of how much of those color blobs, how much of those color cones are you stimulating. And if you stimulate all the colors, you'll see white light. Therefore, for color vision, there is one particular experiment in the laboratory. Well, actually, we have two. For color vision, we have two experiments, and I want you to appreciate that. You will be asked to look at certain graphs, and another test is you want to look at certain shape, and then look at the board, the whiteboard, that what can you see? Look at the black surface or cover your eye, what can you see? It's all about the colors. And you'll appreciate that. I'm so sure of that. Okay, so these will be the didactic principles. And of course, you have counterpart laboratory sessions where you will appreciate these things. Okay, so this is one of the drills that I'm telling you. This is a color blindness test. This is the Ishihara chart. Because with the Ishihara chart, you'll be able to determine if your patient is colorblind or not. Red color blindness, we call them protanope. Green color blindness, deuteranope. Red ito medyo bastos, no? But to help you remember, when I was a student, syempre, ganun ko rin siya tinandaan. Red light district. In the red light district, maraming mga puta. So, red light district puta. So, Prata, no. Okay? Red light district, Deutera, no. How about green light district? Green color blindness, Deutera, no. How about blue color blindness? Tritano. What do you think is the most common pattern of blindness? Especially among my patients, sa tingin ko. Red and green color blind. Mostly they're X-linked. Males are affected. Bakit ko sinabing most of my patients? Because one anti-tuberculosis medication, which is ethambutol, letter E, ethambutol, E, can affect the eyes. Di ba ganun ko pinapa-remember sa mga students? Ethambutol, eyes. It can affect your eyes, particularly the red and the green colors. So you'll have color blindness. If you are taking ethambutol for prolonged period of time, you can have really, totoo yan ha, you can have color blindness. Nangyayari talaga yan. Okay? Next, neural retina. Here, can you still remember I told you about the rods and cones, that it is a hyperpolarization change? Okay, so that is true. But there's one thing that I want to clarify with you. All parts of the retina, can you look, yung mga bipolar cells, horizontal cells, amacrine cells, they all make use of what we call electrotonic conduction. When I say electrotonic conduction, it is different from action potential. When I say action potential, it is an all or none. Whether the stimulus is very strong, whether the stimulus is less strong, whether the stimulus is very weak, as long as it is a threshold stimulus, you will reach the critical firing level, there's action potential. When I say electrotonic conduction, it is not all or none. It is therefore a graded conduction. So all layers of the cells in the retina will make use of electrotonic conduction except the ganglion cell. Because the ganglion cell dapat mabilis. From the ganglion cell, it should go to the cortex. So the ganglion cells will make use of the action potentials, while all these other cells will make use of electrotonic conduction. Why? What is the importance? Because if I'll shine a light on your eye, but yung light na ginagamit ko very weak, bombilya lang, light bulb, very weak. So I will just stimulate a few rods and cones. I'll just stimulate a few of these cells. But if I'll shine a headlight ng car, ng Mustang na car, racing car, the headlight is shined on your eye. It's a very strong stimulus. So it is a graded conduction. The stronger is the light shined on your eye, of course, more and more of those cells will be stimulated. Unlike action potential, whether you use a light bulb, whether you use a pen light, whether you use a headlight ng kotse, as long as it is a threshold potential, you'll have action potential. But this one, they would make use of electrotonic conduction. Remember that. So hindi siya all or none. What cell or what layer would make use of action potential? It is the ganglion cell layer. Okay, remember that by heart. And of course, glutamate is the main neurotransmitter agent if it is stimulatory in nature. Bakit stimulatory? Because you have other cells that are inhibitory in nature, like your horizontal cells, some bipolar cells, some amacrine cells, okay, are inhibitory in nature. These horizontal cells are colored fuchsia or magenta because they are the main cells that are inhibitory in function. If stimulatory neurotransmitter agent is glutamate, what do you think is an inhibitory neurotransmitter agent? Your GABA is an example of a neurotransmitter agent that is inhibitory in nature. Next week, when you talk about motor system, it is a very fun topic. We will be talking about glutamate. We'll be talking about GABA, the glycine, because we will be talking about a different pathway, pyramidal pathway. We'll talk about the dopamine, the D1, D2 pathways, the striatal pathway. So we'll be talking about all those different neurotransmitter agents. It'll be fun. Okay? So bakit ko sinabing there's always an inhibitory neurotransmitter agent? Remember, if I'll shine a light into the retina, I only want to stimulate this particular part. So if this is a light beam, and it will stimulate this area. So this is the excited area. Same is true with general senses. I'm pretty sure Dr. Ronald Alan Cruz has discussed the general senses. There's a theory called the principle of lateral inhibition. You will be able to further or exactly localize that this is the stimulated part because you have what we call the lateral inhibition. If this area is excited or stimulated, all the peripheral part should be inhibited. So the horizontal cells, amacrine cells, and in fact, if you'll be reading on textbooks, the bipolar cells would also have contributions to inhibiting the other cells that should not be stimulated. What's the reason behind this one? Because you want that stimulus to reach this part of the retina where you want to be excited. The excitatory neurotransmitter agent, glutamate. Do not forget that. Kasi maraming student, they get confused with glutamate sa glycine, sa GABA kasi po yung letter G. Okay? Monosodium glutamate, vetsin. No? Glutamate, nako, do not forget that. Okay? Neural retina, again, we're almost done. This one, ipapass through ko lang, not very, very important for you to remember, but I just want you to know that the amacrine cells and the other cells, bipolar cells, like what I've told you in the other picture, very important for the lateral inhibition, okay? Now, remember, I told you in the fovea centralis, the vision is very sharp. It has the highest visual acuity because the layer of the retina is thinnest in the fovea. Reason number one. How about reason number two? The innervation, okay? In the fovea centralis, most of the cells, or I should say all of the cells in the fovea centralis are cones. Cones. Halos wala siyang rods. If I have more cones in a particular part of the retina, I can appreciate color better. I can appreciate the beauty. So the acuity is higher, is better. So I have three reasons. First reason, the fovea centralis, thinner layer of the retina. Number two, 100% or purely cone pigments ang nandoon, cone photoreceptors. Third reason is the ganglion cell numbers, okay? So one ganglion cell should synapse with rods and cone. So if I have 100 million rods, 3 million cones, but I only have 1.6 ganglion cell. How can one ganglion cell synapse with one rods? E di maubusan siya ng mga ganglion cell because you only have 1.6 million ganglion cell. So in the peripheral part of the retina, one ganglion cell can synapse with more rods and cones. However, in the fovea centralis, the ratio is very small. In fact, it is so small that one ganglion cell can innervate or synapse with one cone. 1:1. One patient, one doctor. Tutok na tutok, bantay na bantay. As compared to the peripheral part of the retina, one ganglion cell, 2 million cones, 2 million rods. So hindi siya tutok. Just like in the hospital, if you're in the ICU, one nurse, one patient. Same in the fovea centralis, one ganglion cell, one cone. If you're in the peripheral wards, semi-pay, semi-private, service ward, you have one nurse taking care of 20 patients. So, hindi ko sinasabing hindi na babantayan. Mas hindi na babantayan naman talaga. Okay? Because hindi ganun ka-critical yung case. Okay? Should I rephrase it that way? Okay? So, three reasons. Thinner layer of the retina, 100% or purely cone pigments. Number three, the synapse. Fewer or smaller ganglion cell to cone synapses. Smaller ratio. Do you follow? Okay. Now, we are in the retina. We have what we call the ganglion cell. Final layer na. Makaka-move on na tayo sa retina. So now, ayan na si ganglion cell. We have three types of ganglion cell. The W, X, and the Y. One of my favorite questions in the exam would be the ganglion cells. We have three types of W. They are 40%, hindi masyadong madami, small and slow for crude rod vision. When I say crude rod vision, this is your black and white vision. Remember those by heart. I have X cells, 55%. Fine visual image. When I say fine visual image, high definition, cone vision. So when this is a cone vision, this is color perception, cone vision. So X cells, sabi nga natin pag medyo bastos yung mnemonics, mas natatandaan mo. If you watch X-rated films, X-rated pictures, X-rated movies, color. So X-rated, X ganglion cell, color, mas malinaw, mas maganda. Okay? W, from the word white, W, black and white. White, W. White, crude rod vision. X cells, fine color vision. Y cells, black and white. Okay? So W and Y, black and white. Y, W. If you get the rhyming words, Y, black and white. In fact, the Y cells are the largest. They are the fastest in transmitting signals. Fastest in the context of the action potential transmission. Because from the ganglion cell, what did I tell you? It will be action potential from the ganglion cell to the visual pathway to the cortex na yan. Okay? So W, X, and the Y. Okay? Remember, W and Y, black and white. Rod vision. X cells, color, cone vision. Now, we go to the visual pathway. Because in the visual pathway, you have the new and the old pathway. For the old pathway, you have the suprachiasmatic nuclei, which can control the circadian rhythm. And you have your hypothalamic function. Circadian rhythm, actually the old visual pathways are very, very important, especially for primates or for primitive animals. Because primitive animals, they cannot see or they cannot decipher what is the clock telling us. It's 11:15 a.m. They would not know, 11:15 a.m. this morning, or it is night. They cannot. So they have to rely on their suprachiasmatic nuclei, because the suprachiasmatic nuclei is very important for circadian rhythm, day and night cycle. That's why during a total solar eclipse, again, yung hindi pa totality, you can hear the birds chirping, you can hear the cicada na gumagana making sounds. But once it's totality, madilim na, you can see the abrupt silence, like dead silence, the sound of silence. The birds would go home to their nest because they think it's already nighttime, because they do not have a very high functioning cortex. So their suprachiasmatic nucleus, nakikita nila, ay madilim na, circadian rhythm, will go back home. After 4.5 minutes of totality, lumiliwanag na, they begin to chirp again, they are coming out, so you can hear the murmuration of the birds again. So you can see the flapping of their wings. So umaga na uli, because they're relying on their suprachiasmatic nuclei. Next, pretectal nuclei for the pupillary light reflex, midbrain, tectum of the midbrain. I'll discuss that later, the light reflex. Superior colliculi, do not mistake yourself, because I'm pretty sure you have already discussed your physiology of audition, hearing. In physiology of audition, you have the inferior colliculi as one of the parts of the auditory pathway. But for the visual pathway, it has to be the superior colliculi. Okay, don't forget. Very important for fixation of vision. Very important for animals, especially for birds of prey. When I say birds of prey, yung mga eagles, peregrine falcon, condor, vultures, they should have a very sharp visual acuity. They should have a very high function superior colliculi, because when they are flying and they see this prey, there's a mouse na gusto nilang kainin, they should lock in their vision. They should lock in the target with their vision while they glide down. catch that poor victim. So supracolliculi for locking in of that vision. Fixation. Do not forget. Again, next, ventrolateral geniculate nuclei. Mas tanggalin mo na yung ventro para hindi nakakalito. LGN, the lateral geniculate nuclei. It is very important. For vision, it is a lateral geniculate nuclei. For audition or hearing, it is your medial geniculate nuclei. Do not forget those. Natatandaan niyo pa ba yun? Kasi in the final exam, it is not just the midterm topics. It is physiology A to physiology B. So do not forget that. Okay? Now, from the ganglion cell, it will go through the lateral geniculate body before going to the visual cortex. So it will pass through the visual pathway through the lateral geniculate nuclei. In the lateral geniculate nuclei, you have two pathways, the magnocellular and the parvocellular pathway. I will not task you to memorize. It uses the 1 and 2, 3 and 4, 3 and 5, whatever. Hindi siya tinatanong sa board exam. But the magnocellular pathway of the lateral geniculate nucleus, singular, the magnocellular pathway of the lateral geniculate nucleus will transmit what? The impulses from the Y ganglion cells. Because Y, ano sabi ko, is the largest ganglion cell. So the magnocellular pathway will transmit the Y ganglion cells impulses using the large neurons, malaki, because Y ganglion cells are the biggest. Rapid, mabilis. Y, black and white. White, black and white. So rod vision, poor accuracy. While the parvocellular pathway of the lateral geniculate nucleus will make use of the small and medium-sized neurons of the X ganglion cell. X, mabagal, slow. X, color vision, cone vision. So if you have color vision, high accuracy. Tinatanong to sa exam, so I'm sure you really have to know. So the visual pathway, particularly the lateral geniculate nuclei, would have two pathways. Magnocellular, malaki, mabilis, Y ganglion cell, black and white, poor accuracy, rod vision. Parvocellular would make use of what? The impulses, the action potentials from the X ganglion cell. X ganglion, X-rated, X, color vision, malinaw, high definition, high accuracy, cone vision, slow in transmission of impulses. Clear? Now, oh my gosh, last part now. The visual cortex. So from the ganglion cell, action potential going to the lateral geniculate nuclei, it will now reach the visual cortex. Remember, I told you in the lecture in vision, in higher center, the visual cortex is located where the occipital lobe, particularly the seat of the visual cortex, is a calcarine fissure. The calcarine fissure is a major seat of the visual cortex, and we have three Brodmann areas. You have the 17, 18, and 19. The Brodmann 17 is also known as a striate cortex, S-T-R-I-A-T-E, striate. Striate meaning presence of striations, may maguhit-guhit. So the Brodmann area 17 is a primary visual cortex. It is also known as a striate cortex. While the 18 and 19 are the visual association cortex, or the secondary visual cortex. See? So primary visual cortex, striate cortex, or Brodmann area 17. If I have a problem in my Brodmann area 17, I cannot see. But if I have an intact Brodmann area 17, but my problem is Brodmann area 18 and 19, I can see you, but I might not know what am I seeing. I cannot associate ano ba yung nakikita ko. Okay, clear? So as a review, I have ganglion cells, Y ganglion cell, what kind of dorsal, what kind of lateral geniculate pathway do I use? It is particularly dorsal lateral geniculate, but LGN pwede na. So what kind of LGN nuclei? The magnocellular pathway. Why? Malaki, fast, black and white vision. How about my X-ganglion cell? Maliit, very accurate, color, cone vision. This would send action potential to the lateral geniculate nuclei. But I'm not happy with just lateral geniculate. It has to be the parvocellular pathway for the X ganglion cell. Y ganglion cell is magnocellular. You have to remember this. And where would they terminate? Because the visual cortex, I told you, the primary is called the striate cortex because there's presence of striations or lines or columns. You have 1 to 6. Do not have to memorize because bakit mo pa memorize? Both of them lang naman will terminate at layer 4, period. That's it. So whether you are using the magnocellular or parvocellular, both of them will terminate at layer 4 of the visual cortex. Clear yan, ha? Okay. Visual field. This one, you will do this one where in your laboratory, we do the perimeter or the perimetry test. Okay? So there's a tool. Makikita ninyo doon, maganda siya, very modern. No, I'm just kidding. You will see the tool on how to determine the visual field. So I will not discuss this further because gusto kong ma-discuss ninyo in your conference. Visual field, you have to tell me or tell us which part of the visual field is broader, the nasal part or the temporal part. Okay? This is very important. Very important. When I say very important, you have to know this by heart. However, I am training you to be students of medicine. I'm not training you to become ophthalmologists. I'm not training you to become physiologists. So just listen to me and follow, okay? First, these two are the eyeballs. Yes, of course. Walang tututol dyan. Walang magkukontradict. These are the eyeballs. Right eye, left eye. Are we clear? Right eye, left eye. Follow my cursor, huh? Right eye, left eye. The entire thing that I can see will be the visual field. What did I tell you? The right visual field is nakikita ng, for example, right visual field is seen by this right eye because the visual field is also divided into two. The right visual field will have the nasal and the temporal. Temporal yung nasa gilid, nasal yung nasa near the nose. So the right visual field, you have the right nasal and the right temporal. And the right nasal visual field is registered in the right temporal part of the retina. So this is registered here. This part here is registered here. So the right temporal field is registered in the right nasal retina. The right nasal visual field is registered in the right temporal retina. Clear? Clear yan, ha? Opposite is true sa left eye. Now, let's try to look at the retina. The retina here, you have the, of course, your optic nerve. So the optic nerve, you have two tracks. You have the nasal and the temporal. The nasal will go down, 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 down until it reaches the optic chiasma. Once it reaches the optic chiasma, it will decussiate to the opposite side. Take note of the blue line. The nasal part of the optic nerve will go down to reach the optic chiasma. Once it is in the optic chiasma, it will decussiate to the opposite side. However, the temporal part of the optic nerve will go down. It will reach this part of the optic chiasm, but it will not decussate. It is ipsilateral. It will just go directly to the brain. However, the nasal part will go to the opposite part of the optic chiasma before going to the brain. Therefore, the right nasal part of the optic nerve is decussating to the opposite, while the temporal part is ipsilateral, non-decussating. Clear? Okay. Now, let's try to talk about the different patterns of blindness. I know this might be very difficult. I promise you when I discuss motor system physiology, I will sacrifice 5 minutes so I can draw this on the board. Okay? So if I destroy the right eye, which part do you think I cannot see? Of course, pag nasira tong buong right eye, I cannot see the right visual field because I destroyed the nasal and the temporal. Therefore, what kind of blindness? Ipsilateral monocular blindness. One eye blind. Okay? So destroy the eyeball, it is an ipsilateral monocular blindness. If I cut the optic nerve, same as the destruction of the eyeball, ipsilateral monocular blindness. Sakit ng throat. Sorry. If I have a tumor in my pituitary gland that would erode my sella turcica, and you know that when you erode the sella turcica because of an encroaching tumor, you can impinge of the optic chiasma. If you impinge of the optic chiasma, what can you impinge? The nasal part of the optic nerve. So you impinge the right nasal and the left nasal. What part of the visual field can the nasal part see? The temporal. So if you impinge this left nasal, you impinge this right nasal, and you know that this nasal will let you see the temporal part of the visual field here, the temporal part of the visual field here. So you are like a kalesa, a horse. Yung merong, ano ba sa Tagalog? Doon, hindi ko alam. Yung may ganyan, yung may blindfold sa gilid. So you have bitemporal hemianopsia. So imagine yung kalesa, yung kabayo. Imagine that kind of blindness. They cannot see the side. Bitemporal hemianopsia. A problem or a tumor in the pituitary gland, an adenoma that will impinge on the optic chiasma. Clear? If I cut the optic radiation, if I destroy the lateral geniculate body, if I destroy the cortex, the visual cortex, what can you see or what can you not see? Imagine, if I cut this optic radiation up to the optic, if I cut this optic radiation up to the visual cortex, let's try to track or trace. Look at the arrow, my cursor. Right cortex. This is yung red is the right is the temporal. The temporal, you look. Trace, 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 trace. Oops, ipsilateral. So dito pala. So blind ako dito sa right nasal visual field. Look at this blue in my cursor. Saan nanggagaling tong blue? Where did this blue line come from? Let's try to trace. Up, 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 up. Oops, I'm here. The lateral geniculate body, same side pa rin. Trace, oh, we are in the optic chiasma. It is from the left eye. Therefore, it is from the left nasal part of the optic nerve. And the left nasal part cannot see what? If this is problematic, you cannot see the left temporal part. So you cannot see the left temporal, you cannot see the right nasal. So almost same side. You cannot see this, you cannot see this. So this is homonymous, same side. Homonymous, homo, same side. Homonymous hemianopsia. So you'll have this pattern of blindness. Okay? The rest, I don't want you to confuse you anymore. You want to make chondrantinopsia, superior, inferior. Okay na yan. I promise you I'll sacrifice 5 minutes of my lecture in motor physiology to draw this on the board with colored chalk so you can appreciate this one because this is very, very important. Okay? Last part. Since we are not anatomy class, I will not ask you to enumerate what are the muscles innervated by the superior oblique. Well, in fact, isa lang, SO4, lateral rectus, cranial nerve 6, and the rest, cranial nerve 3. But I will not ask you what will be the movement responsible for looking, what muscle will be responsible for looking to the left, right? No. But I want you to remember, we have what we call the MLF, the medial longitudinal fasciculus. Medial longitudinal fasciculus is a cranial nerve nuclei. What Did I tell you about nuclei? They are groups of cell bodies found where? Inside or outside the central nervous system? They are found inside the central nervous system. Since they are what we call the cranial nerves, so yung mga nuclei of the cranial nerves found inside the central nervous system, nuclei, okay? So if you have a lesion, okay, in those nuclei na yan, you can have a problem in the reciprocal innervation of those muscles, innervated by those cranial nerves. What do I mean? Okay, the medial longitudinal fasciculus is made up of the nuclei of cranial nerves 3, 4, 6. You remember, the MLF is made up of the cranial nerve nuclei of those cranial nerves that would have direct action on those extraocular muscles. What is the importance of this one? Imagine, everybody, when you look to your right, now, look to your right. Titingin ako sa right. What muscle is acting on my right eye? Lateral rectus. What muscle is acting on my left eye? Medial rectus. Lateral rectus of the right eye is innervated by cranial nerve 6. Medial rectus of my left eye is innervated by cranial nerve 3. Hala, how can I ask two cranial nerves to work at the same time? That's possible because you have the medial longitudinal fasciculus. But look, I told you I am stimulating my cranial nerve 6 because my cranial nerve 6 of the right eye is being stimulated. But how come the lateral rectus of my left eye is not pulling it to the opposite? Because the medial longitudinal fasciculus will tell the cranial nerve 6 of the right eye to contract so it can look to the left. It will tell the cranial nerve 6 of the left eye to relax so it will not be pulled towards the left. Otherwise, yung mata mo parang goldfish, nakaganyan, nakahiwalay. So it was the medial longitudinal fasciculus that would enable your cranial nerves to have reciprocal innervation. If I am stimulating this one, the contralateral eye should be inhibited. That's why patients with upper motor neuron lesion, we will discuss that next week. Upper motor neuron lesion, like in multiple sclerosis, they would have demyelination of the medial longitudinal fasciculus, loss of myelin. So they will have loss of the function of the medial longitudinal fasciculus. So patients with multiple sclerosis, they will have failure of the reciprocal innervation. When they look here, the other eye will look there. So they will have problems in their vision. Okay? But very interesting if you know the concepts and the principles of those. Eye fixation. This white and black drum is not a referee, okay, or not a uniform of a referee ng wrestling. It is what we call optokinetic drum. You will see the optokinetic drum in your laboratory session, and you will tell us what kind of nystagmus can you see, vertical, horizontal, fast, slow. I want you to read on that, because that will be part of your conference or when you discuss that. But when I say saccadic eye movement, imagine if in a laboratory session, that drum will rotate. Kaya sira na siya, no? So manually natin siya i-rotate. Medyo matanda na siya. So when we rotate that manually, we will be asked to fixate either on the black, on the silver, or the white line, no? So when you fixate and you try to fixate your vision, your gaze, and one scene will just pass by each other. So one scene at a time. One scene of that visual image is what you call a saccade. S-A-C-C-A-D-E, a saccade. So that saccadic eye movement is very important because you want to check or you want to fix your eye in one view. Very important, especially for animals or birds of prey or primitive animals. They should have this saccadic eye movement because they are flying, they're moving, and their victims are also moving. So they should have a very good saccadic eye movement so they can fixate on their gaze, fixate on one point. And of course, if you're reading a book, you read from left to right because that saccadic eye movement can help you extract information from the book. Painting, you look at the painting at the picture, left, right, up, down, because no saccadic eye movement can help you obtain that inner message that the artist would want you to understand. Pursuit movement, especially nga dun sa mga animals, like they have an object in pursuit. Okay? So meron silang hinahabol na object. Saccadic eye movement. Okay? Oh my gosh, naloba. Next, fusion of images. Stereopsis, I told you earlier, depth perception. When you're watching an IMAX or 3D movie, if you have strabismus, medyo mahirapan ka because the right eye might see this visual field, but the left eye might be seeing another visual field. So there's no fusion of image. So inulit ko lang siya because you'll do this in your laboratory test in stereopsis or depth perception using binocular vision. You'll do that. Last but not the least, of course, you have to remember, hinahunt pa din kayo ni autonomic nervous system. In the autonomic control of the eye, especially the pupils, you will see pupillary dilation or mydriasis and pupillary constriction or miosis. Pupillary dilation is caused by sympathetic activity or stimulation. Pupillary constriction is caused by parasympathetics. So remember, okay, dilate, mydriasis. So in the presence of bright light, the pupils will constrict. And constriction of the pupil is because of the contraction of the circular muscles. Do not forget that. The circular muscles, hindi ciliary muscles, it has to be the circular muscles that will cause the constriction of the pupils. The pupillary dilation is because of the contraction of the radial muscles. So radial, letter D, radial, dilate, mydriasis. Sympathetics, dilate. Constriction, parasympathetics. Now, let's try to talk about the constriction of the pupils because we have to know the pupillary light reflex. If this is a reflex arc, we should have both a sensory and a motor branch. Sensory, afferent. Motor, efferent. So pupillary light reflex is made possible because of two cranial nerves. Sensory cranial nerves from the optic nerve, the cranial nerve 2, efferent or the motor nerve from the cranial nerve 3 or the oculomotor. First, when light is shined on the right eye, okay, past tense of the word shine can be shown or shined. But actually, grammatically, it's more correct if you say shine. Kasi iniilawan mo, okay? When the right eye is shined, okay, with a pen light, okay, remember the optic nerve, you have the nasal and the temporal. So what is the receptor? Reflexion. What is a receptor? The photoreceptor, the rods and cones, okay, which would transmit impulses where? Which would transmit impulses saan? Ano na yung afferent branch niya? The optic nerve. And the optic nerve, the nasal part would carry impulses to the optic chiasma to the opposite side, while the temporal part will transmit impulses. Okay? So when I shine the light on the right eye, this right optic nerve, the nasal part, will transmit impulses through the optic chiasma to the opposite part of the brain. The right temporal will transmit ipsilaterally, same side of the brain. It will reach the center. So of course, this is a reflex. You have the receptor, the photoreceptors, the rods and cones. You have the afferent nerve, which is the optic nerve, and you have the center. The center of the pupillary light reflex is in the pretectal nucleus. The pretectal nucleus is in the midbrain. In the midbrain, particularly the Edinger-Westphal nucleus, okay? So in the Edinger-Westphal nucleus, okay, so it would send, kasi yun yung nucleus dun sa may cranial nerve 3. And cranial nerve 3, the oculomotor, is a motor limb. So the oculomotor nerve will now send impulses where? So the right oculomotor will send impulses to the right eye. The left oculomotor nerve will send impulses to the left eye. So if you shine the light on the right eye, which eye are you expecting to constrict? Right eye, left eye, both or none? Both eyes. Because if your cranial nerves 2 and 3 are all intact, This cranial nerve 2 will send impulse to the right eye. It will also send impulse to the left eye. And this left eye will send impulse to the cranial nerve 3 of the left eye. And the of the right eye will send impulse to the cranial nerve 3 of the right eye. So both right and left would be stimulated. However, we have two types of pupillary light reflex, the direct and the indirect. When I say direct, you are shining the light on this test eye and you are observing the test eye. Kung anong eye ang ino-observe mo with that light on, that is a direct pupillary light reflex. When you are observing the contralateral, the opposite eye, that is what you call the consensual light reflex. Consensual light reflex, okay? Next, autonomic nervous system, again, there's a problem sometimes in the sympathetic chain of ganglia. Remember, you have your cervical, thoracolumbar, and of course you have your cranial nerves with your sympathetic functions too. However, some patients will have Horner's syndrome. Some patients will have Horner's syndrome because some of the sympathetic chain of ganglia found in the neck area, they would innervate also and give sympathetic innervation. So patients with Horner's syndrome, there's a problem in the sympathetic group of ganglia. So in this picture sa baba, which one is the affected area? Itong mas maliit na mata or this one yung may mas malaki na mata? This part is affected, the one with a smaller eye. Why? Because with Horner's syndrome, you have the components, ptosis. So mas maliit yung mata niya, mas drop. Ptosis. Ptosis, bakit siya mag-drop? Hindi siya nag-open. What opens the eye? It is your levator palpebrae. Levator palpebrae is because of your cranial nerve 3. So you have ptosis. Meiosis, which one has a bigger pupil? Ito, di ba? And this one has exaggeratedly meiotic pupil, constricted, because this patient has meiosis, extreme meiosis, because parasympathetic nag-overdrive kaysa sa sympathetics. The sympathetic is destroyed, so it cannot cause dilation. So there is meiosis. So you have ptosis, meiosis, and of course the patient has anhidrosis, absence of sweating. Why absence of sweating? Sympathetic cholinergic. Sympathetic cholinergic transmission will give impulses or signals to the sweat glands. If there is sympathetic cholinergic dysfunction, you will not have sweating. So the patient has anhidrosis, very dry. Sympathetic to the blood vessels, sympathetic adrenergic, constriction of the blood vessels. However, you have impaired sympathetic function, no constriction of the blood vessels. The parasympathetic overdrive would cause blood vessel dilation. So there's dilation. So you have ptosis, meiosis, anhidrosis because of sympathetic cholinergic problem, and vasodilation, redness, because you cannot constrict. There's a problem in the sympathetic adrenergic component. So that is your Horner's syndrome. Ptosis, meiosis, anhidrosis, and redness because of vasodilation. Some patients would have a prostitute's eye, mata ng pokpok, prostitute's eye. This is called the Argyll-Robertson pupil. This kind of pupil is because of a neurosyphilis. Sabi nga nila, to help you remember, neurosyphilis, nakukuha because of promiscuity, okay? So, prostitute's eye. They say that prostitutes, if iniilawan mo, hindi lalapit, hindi magre-react. Pero pag nilapitan mo, kakagat, magre-react. So the Argyll-Robertson pupil is, if you shine light on this affected pupil, it will not react, it will not constrict. But if you approach that eye, it will constrict. So what do you think is the mechanism? If this pupil will not react to light, what is another mechanism to make this pupil constrict? Accommodation. Remember accommodation? So the lens becomes thicker. Tapos it is not just the lens becoming thicker. There's also stimulation of the sympathetics, which will cause constriction of the pupil. So you are using another technique to make the pupils constrict, because you can make the pupils constrict in two ways: light and accommodation. Since it is a prostitute's eye, there's neurosyphilis destroying the tectum of the midbrain, which is responsible for the pupillary light reflex. So you can make use of the accommodation to make the pupils constrict, because the Argyll-Robertson pupil is a pupil that will not react to light, but it will react to accommodation. Hindi yan gagalaw pag inilawan, pero gagalaw kapag nilapitan at tinukso. Oh, di ba? May ganun. Okay, so that's the Argyll-Robertson pupil and the Horner syndrome. And I think that is the last slide of my, wait lang. That is the last slide of my lecture in physiology of vision. I told you we'll finish in roughly a little bit longer than higher center. Did you learn something? I hope you did. I know it's a very long topic, but if you have any questions, section B, Wednesday. You can ask me next Wednesday when we do the, but sa ganito, when we do the lecture in motor system next week, if you have any questions, feel free to ask. Or if you bump me into campus, just feel free to ask, okay? So I hope you learned something in the physiology of vision. Next week, I'll see you in motor system. Thank you very much.